Now, this is a very interesting one, right? This uh, this MRI was of a 24-year female patient who presented with right-sided upper limb weakness. She also had partial seizure, that she had involuntary movements of right upper limb, which lasted for a few minutes, and this was the reason why she was brought to the hospital. Now, this was a plain MRI. This is very typical of T1 image. What we can see is when we compare this right side and left side, we can very easily make out that there is some problem here. So this is plain T1 weighted image, and when we can see in this area, this left side, there is reduced signal. We can see that this is a very typical of edema. So on the right side there is nothing, but on the left side there is something over here in this area, most specifically in this area. So there is reduced uh, in signal intensity, you can say. It is very obviously in this area. So it means that there is some problem in this area. So to evaluate it, we have other images of MRI which will tell us about the exact problem. So this was the plain T1 MRI, and when we did the contrast enhanced MRI of the same patient, what we found was there were two lesions which were ring enhancing lesions. Can very crystal clear see here and here. So this one is a ring structure which completely got enhanced, which we could not see on plain T1 MRI. And this is the second contrast enhancing lesion, ring lesion, which was not there or which was not very apparent on T1. So you can see that this lesion got enhanced on this contrast. That is the beauty of contrast, because it enhances the problem wherever it is. So we can also see there is edema in this area. If you see, this is the white matter which looks white, but here this white matter has more of a reduced signal from it, which suggests that this is edema. And we know whenever there is edema, it actually increases the intracerebral pressure. It can cause convulsion because of this marked edema. So there are two ring enhancing lesions in this patient, in this left uh, posterior parietal, posterior frontal region and high frontal region, which were present with edema. And this is a flare imaging where we can very nicely make out the edema part. Here we can very nicely make out the edema part which is there. That is the reason why this DWI, ADC, these all other images are excellent to find or to evaluate this problem in a very beautiful way. We also did MRS, that is spectroscopy of this patient, which showed increased lactate, increased lipid lactate. So increased lipid lactate is very commonly seen in TB, or we more of a tuberculoma of brain. What this tuberculoma of brain is actually a brain lesion which is caused by TB to the patient. Whereas we find the increased amino acid levels in patient with uh, NCC, that is neurocystic sarcosis. So it is one of the differentiating point, or it which can help us to find whether it is tuberculoma or whether it is neurocystic sarcosis, because we must know they are very commonly found and they are very commonly problematic to compare always. So it is always we need to understand, if lesion is more than 2 centimeter, it is more than 2 centimeter, it favors TB. If it is less than 2 centimeter, it favors NCC. NCC can be multiple in numbers. Patient may have hundreds of small granulomas, whereas in tuberculoma or tuberculous TB lesions, it's very commonly few discrete nodules or few discrete lesions. You may get around 3 to 4 to 5 to 6 tuberculoma lesions, but in NCC, it can be in hundreds. So it is very important to come to know key what favors what. So if it is less than 2 centimeter, it favors NCC. If it is more than 2 centimeter, it favors TB. If there is marked edema, then it favors TB. Whereas in NCC, edema is not very commonly found. NCC can be in hundreds of lesions, whereas tuberculoma you found few discrete lesions. Now these few discrete lesions can conglomerate. Can conglomerate means mix and form a large lesion, whereas in NCC this conglomeration is not a feature. And usually patients with tuberculoma, they almost always have chest TB. Just like in our patient, she had pulmonary tuberculosis, and she also had her mother who had TB, which was treated and which was cured for after taking the treatment for 6 months. So, family history or close history of TB is extremely common in tuberculoma of the patients, whereas in NCC, it is not the thing. So, presence of marked edema also favors NCC. Is not a feature of NCC, whereas there is marked edema in presence of TB. And when about magnetic resonance and spectroscopy, we talk about this NCC shows us multiple amino acid level peaks on the spectroscopy, but on this tuberculoma, we see lipid lactate peaks, which is very typical or which favors the diagnosis of tuberculoma. So this was a very interesting case. Uh, One more thing in this neurocysticercosis patient, that the MRI may show scolex formation or calcified granulomas or ring enhancing lesion. So whenever we are talking about scolex, scolex is usually a lesion with a eccentric head. Scolex means actually head of this neurocystic sarcosis lesion. So this type of eccentric scolex with a ring structure is what is we call it as scolex lesion. And this scolex lesion is a very, very, very typical of NCC, which is not seen with this tuberculoma. So this was a very interesting MRI showing tuberculoma with two discrete lesions with significant mass lesion presenting as convulsion. Thank you.